Hi, so what I thought I'd do today is just chat a bit about some of the things that I've learned from working in a multidisciplinary team over the past few years. So I've had various roles. I've worked in 2 different types of hospital settings, so acute and then a community smaller hospital as well. I've worked both within the hospital and then during the pandemic I've also supported a new service where we're trying to facilitate discharges whilst not being based in the hospital, so sat with a multidisciplinary team. I've done crisis work and I've worked in the community alongside health colleagues as well. So when I was in the community, this is my current role actually, and I'm attached to a GP surgery area, and it's working really closely with the district nurses and then also working with trying to prevent people actually being admitted to hospital. I've worked in a rehabilitation centre as well, and that was working with health and various professionals as well. So I'm going to do a few videos like this, but I thought I'd just give a few sort of ideas of things I've learned over the years because I thought it might help people going into these sorts of teams. The first thing I'm thinking is that a big thing that I learned quite early on was when I was actually in the meetings, a lot of the time they were led by either nursing staff or team leaders from the caring side, and I was sort of there to share my perspective alongside the therapist. I often found myself actually taking more of a lead on the meetings, and I think that naturally happened because I was the one that was really advocating for what the person wanted, and it was sometimes quite difficult because at first, because I recognised that there was an issue with sometimes the person in the room, their voice would get lost, so very quickly I learned how to make them more of the main focus in meetings. So one of the things I did was that I'd try and do a bit of an initial assessment before I'd go into a meeting, just to make sure that I'm really clear on what the person's values are and what they wanted and how they saw their life panning out sort of when they move forward with what they wanted to achieve. For this, I'm thinking about when I mainly worked in a rehabilitation centre. A lot of the time we were having big meetings to decide about the progress where they were and then looking at when they leave as well. So some of the times it was looking at people going into 24-hour care, but mainly it was looking at people going home afterwards. So I recognised that there was sometimes when I first started where people would sort of go along with it in the meetings, and then I'd go and speak to them afterwards and they'd say, well, you know, and they'd look a bit upset. This was one person in particular that I'm thinking of. And when I got into it, I realised that it was because he took a long time to get ready in the morning, up to like 4 hours sometimes, and that was looked upon as like not normal really compared to everyone else. It doesn't generally take that long. So the decision was made that he'd have some support at home, and that included equipment, and it sounded great in the meeting that we'd go ahead and do that, but afterwards he said, I just don't want it. And I said, oh well, why is that? And he said, well, a big part of my identity is the fact that I can actually manage these things on my own, and I feel like that would take away who I am. Because he'd worked in the military, that was clearly important to him. And it just made me reflect on the importance of knowing that up front, and then I know exactly sort of what I'm advocating for and looking at ways around it. And another thing I thought with that example is sometimes people can decide that they don't want the support, but making sure that they're clearly aware of their options and making it very clear that, you know, it's the individual's choice and you're not going to force anything on them also means that they're more likely to actually ask for help in the future. So sometimes I'd find that they'd say no to support but then return home and find that they'd struggle and then give me a call and I could just put something back in place. So I think it's just about making sure people are aware of those options. So I think also a big thing I've recognised is we are in a powerful position as professionals professionals, and sometimes that can be a good thing because we can help give them more choice and access to services and help them with the things that are important to them. But there can also be a really negative side to it as well when we're looking at things like coercive power, and that's something we need to be aware of. For this, I think of an example that I saw where someone was so keen on proving to professionals that they could actually manage on the stairs in order to return home, that during a stair assessment they actually was really rushed and walked really quickly, and that actually put them at more risk because they were trying to do that. And I just thought that we should never be putting people in a position where they feel that they're proving something to us, or that, you know, what we should really be doing is getting people on an equal thing with us. And I think it's sometimes useful to think of transactional analysis with that, actually, where we don't want to become like a parent-child sort of roles. We want it to be like adult conversation, and we can do that by being really respectful, saying what our role is, what we're there to do, not do, and then also just sort of make sure that we're listening to the person, because I don't think we can ever actually help people without knowing what it is that they want out of their life, because everyone's so unique and different. Another thing I wanted to say was sometimes there's a tendency between health and social care to focus on different things. So within the medical model, people are looking a lot at sort of diagnosis and looking at how can we fix the problem, and often that looks at the physical sides of things, which is really important. We can't dismiss that. That's what people need help with. But then also from a social care perspective, looking at that, we also place a lot of emphasis on emotional well-being as well, and also looking at other factors. And also with the medical model, the expertise is generally looked upon within the profession, whereas the social model, it's more looking at the person as the expert on their own lives. So sometimes that can manifest in conflict between the two. And the literature that I've looked at around people that are working in health professions is that sometimes they can prioritise physical well-being above other things, and I have seen that played out in real life in the situations that I've been in. I remember a person that I was trying to support who wanted to access the community and felt very lonely, and they wanted to engage with others, and we spoke about that in a meeting with other professionals, and it was sort of downplayed, like we were wasting time talking about it in the meeting, because they felt that the priority was making sure that the person would be able to walk well and things like that. And I think that often our role doing that can sometimes be downplayed, but that's so important. And it's important to remember that we are actually all working within the same piece of legislation. So even so the Care Act, for example, everyone's working within that, whether we're health or social care. So one thing that comes into it there is the well-being principle. Under the well-being principle, there's actually no hierarchy to well-being. So physical and emotional well-being, none of it would be seen as more important or less important than that, than each other. So what I'm thinking of is sometimes we think about basic things like eating and drinking and getting washed and dressed as being more important, but the Care Act doesn't say that. It says that access in the community is just as important and things like that. So that's just something to keep in the back of your mind. So there's something called the protection imperative, which Judge Ryder talks about, and that's where professionals are unable to work objectively if they place too great a focus on the need to protect older adults. That's something that's really helped me in my practice, thinking about that, and it's something that I learnt about more in depth when I did my best interest assessor training. And I think we all need to be aware of our own susceptibility to bias as well in situations of uncertainty. So quite often as professionals and social workers, we are carrying a lot of risk, and I think it's good to recognise that that can make us feel uncomfortable at times, especially if we're the allocated worker, responsible, and we feel that we're trying to manage a lot of things, and the person's saying, you know, that they want to go home, and a lot of people are saying that it's that that's dangerous and it can be really stressful. However, our role is not to just take away all risks, and I think that's important to think about because, for example, I had a lady who there were a lot of risks with her returning home. She had no family around, so she didn't have that sort of network. She did have cognitive impairment. She was really struggling with a lot of things, and she had sensory impairment, so she struggled with her seeing and hearing as well, and especially because she was needing such a lot of help. But a decision was made by my colleagues that it would be impossible for her to return home. And the decision was also made that she lacked capacity. And in this situation, I actually challenged that and I said, well, have you assessed her capacity? And the answer was no. And I went and did a capacity assessment, and it did take a long time to do because she was someone that it was difficult to communicate with, but I persisted. And with the Capacity Act, obviously we're meant to go and repeatedly try and give the person the best chance to engage in the process. So luckily for me, I was working in a place where I could go back every day for a week, which I did. And I did find a way to communicate with her. I sort of got on her level and found a way through it. And the outcome of the assessment was that she had capacity. At this point, other professionals withdrew their support because they felt that it wasn't safe for her to return home. This was a big learning point for me because what I had to do in this situation was actually support her to go home without the support of the people I usually had around me to put equipment in place and things. And I understand why, because there was such a high concern and the staff were worried about what would happen if she returned home. So I had to be creative about how I supported her going forward. So I ended up getting community services involved with getting equipment in place. I got the fire service involved to minimise some of the risks, and I got a high level of support in her home. And in this situation, she actually did really well at home, and yet she was thriving by a couple of weeks in. And I think what it taught me is that we have to be really careful to look at the situation and manage the risks, but not try and take away every possible risk, because as much as we can risk assess, we can't eliminate all risks. And it's something that Judge Mumby said, where he said that what's the point in making someone safe if it merely makes them miserable? I think that's particularly relevant with this lady's case, because what she said to me was that she'd lost a partner and it had been quite traumatic because she hadn't been able to see him when he was at the end of his life, and then she'd gone into hospital and all she wanted was to go back to her own home so she could have the memories of him, and that was so important for her. And that could have been taken away really by her just going into 24-hour care. And by doing that, there would have actually been a risk of a decline to her emotional well-being and her mental health. Taking away one risk can also sometimes increase the likelihood of another occurring, because we'd taken away, if we were to manage all the risks around her physical well-being, it could have been, like I say, a risk to increasing the decline to her emotional well-being. So I just wanted to finish and say that we need to be careful not to take a rule of optimism. And what that means is that we're just so focused on looking at people's strengths and what they can do that we actually minimise risks and don't notice them. So social workers have sometimes been criticised of this in serious case reviews, and I just thought it's something to bring up because it isn't something that just affects when we're supporting children, it can affect adults as well. And I'll bring up a piece of case law which I'm thinking of here. And I think it's just sometimes we have to be careful that we don't get so engrossed in a battle with health and between health and social care that we forget that there's a person in the middle of it and that it's just about what's right for them. And sometimes what we decide is right for them can change over time, and it's a two-way process between yourself and the individual and the other assessments. But it's about looking at everything really carefully and not just making quick assumptions. So that's why the analysis is really important, and that we're putting case notes together. I'm thinking that I'll go into managing risk and some of the things about that in the next video. Thank you. If you enjoyed the video, please can you like and subscribe and press the bell if you'd like to be updated when I put out more videos. Thank you.